or you can WhatsApp anything. Like say, mail it.
Good afternoon, everybody. I am Rahul Chobe from Physiotv for today's webinar on frozen shoulder busting the myths. I am handing over this session to Dr. Nikita, who will introduce the speakers. Over to you, Dr. Nikita.
Hello everyone, welcome to Frozen Shoulder Busting the Myths. So we have found so many patients, or as a physiotherapist ourselves might have experienced one or the other some time of our life. So we have many notions around the point that what exactly is frozen shoulder or what exactly happens in an adhesive capsulitis. So here we are here to bust those myths, whatever, as a surgeon, Dr. Nilesh Kamath sir will be introducing us to the whole world of frozen shoulder from a surgeon's perspective. And we have Dr. Sania, a physiotherapist at Sanjeti Institute of Orthopaedics and Research, to guide us on the clinical aspects of it. Now I'll introduce you to our speaker for the day, Dr. Nilesh Kamath. He is an arthroscopic and a shoulder surgeon. He graduated from BVMC and postgraduate. He completed his post-graduation from KEM Pune. He was trained overseas at Sligo General Hospital in Ireland, where he studied mostly in the upper limb unit. Then he completed his clinical fellowship at Singapore General Hospital in Orthoscopic Surgery and Sports Medicine before returning back to India. We're glad he returned back. Then his special interests are reconstructive shoulder and knee arthroscopic surgeries. He's been a national faculty at IAS, IOACON, then PKC and PCS. He's also a part of core organizing team for Pune Knee Course and Pune Shoulder Course since its inception. He's also an office bearer of IAS as a part of the executive committee. We welcome you, sir.
Thank you. Right, so do you want me to take it on from here?
Yes, sir. Sure.
Okay. So thank you so much, Nikita. Thank you for those kind words. At the outset, let me start off by thanking Sancheti Hospital, Dr. Parag Sancheti, Dr. Bedekar, my entire physiotherapy team, and all those who are involved in this academic initiative of PhysioTV, where a topic is touched upon and we try to, more than teaching, it's trying to exchange ideas and to learn from each other as to what this entire clinical scenario is all about. So today, on purpose, we have chosen this topic on frozen shoulder because this has been a clinical dilemma for all of us, and hopefully, I get to share my thoughts as a surgeon, as a clinician, and at the same time, I get to learn from you what would be beneficial from your side, because we know that the final aim from our end, either yours or mine, is going to be same, that is benefit of the patient. So I'm going to do a screen share and I'm going to start off with my talk. So just give me a second. Is my screen visible? Can someone validate that?
We can see. Yes.
So we have Sania also, who has joined us, and it's really been a pleasure working with Sania. She's been one of the most forthcoming and able physios, and it really helps a lot, because this is something very important that I would like to emphasize, that if a good clinician does not have a good physio hand in hand, whether it's just clinical scenarios or surgical outcomes, they are going to be suboptimal. And any shoulder physio or any shoulder surgeon will vouch by this, that you need a good physio to really take his clinical results forward. And I would like to take this opportunity to thank Sania as well.
So thank you so much for the kind words. Thank you.
Right. So the first thing that I would really start off by saying is don't jump to premature conclusions. And what do I mean by this is that you really don't need to blindly follow the fact that if someone else has written that the patient is suffering from a frozen shoulder, that means that he's really suffering from one. Trust me, as orthopedic residents in India, a good 20-25 years back, the only clinical scenarios that we were aware about was either a frozen shoulder or a rotator cuff tendinitis or a rotator cuff tear or biceps tendinitis. I don't remember being a resident and thinking beyond these diagnoses because the shoulder has always been the dark corner of the human body. Clinical examination of the shoulder has always been deficient, and the rotation in the shoulder would always be 1 or 2 months, which would barely allow you to learn something. So what is a stiff shoulder? And this is something important. All stiff shoulders, according to me, are not frozen shoulders. So when you see a patient with a loss of movement, I think the first thing that we need to identify is that, is it a classical idiopathic primary frozen shoulder, or is it an acquired or a secondary form of frozen shoulder? And what do I mean by this? If you're looking at a primary or an idiopathic shoulder, you're looking at a global stiffness, basically caused by a capsular contracture, and there may not necessarily be any trauma or any surgical intervention as such. Now, what is an acquired shoulder or acquired stiff shoulder is that entire genre which comes in post-traumatic shoulders or post-surgical shoulders, or if there is an inflammatory arthritis or osteoarthritis. Then what about those patients with a rotator cuff tear? Because it's not unusual to find a patient who's having this partial cuff tear on MRI, and all of you are able enough to read your MR images, and you'll see these reports which are mentioned, either a partial cuff tear or a full thickness cuff tear, and patients really are having a very stiff shoulder. So there's this paper which had come up from Sugaya, and Sugaya is one of the biggest names from Southeast Asia, from Japan. And what he proved was that shoulder stiffness with severe and global loss of passive range is not associated with a full thickness cuff tear. Yes, partial thickness cuff tears still remains a clinical enigma. But if you're looking at a full thickness cuff tear, you will not get that kind of stiffness with passive range. So that's something which we need to know, because if you're clinically examining a patient and passively, if you're able to move him through a little bit more than what he's able to do actively, you're not really going to put in frozen shoulder as what your diagnosis would be. So when you're looking at restricted range, there could be 3 clinical scenarios, right? One is your passive range is more than your active range, right? Typically associated with weakness. In that scenario, think about a rotator cuff tear. Your x-rays are not going to clinch the diagnosis because it's going to be normal. If your passive range and your active range is equal and practically in all planes without any weakness, and this is something which even residents have asked me, that how do you assess for weakness in a frozen shoulder? Well, you're not really going to classify it as grade 1, 2, 3, 4, 5. No, what you're trying to do is, let's say if you're doing a full can, don't do an empty can, because in an empty can, remember, you're going to rotate. As soon as you bring about a rotation, we all know that in frozen shoulder, as it is, rotations are quite painful and they're restricted. So if you're going to bring about an internal rotation and do an empty can, that patient is never going to be happy and he will never really give you that kind of resistance. As opposed to that, in a full can, if there is an end point, that means even if you're trying to push down and the patient is able to resist, it's less likely to be a rotator cuff tear. When you're looking at a glenohumeral arthritis, well, in those scenarios, the X-ray is mandatory, because again, why have I put arthritis here as a differential is because understand that in a classical primary shoulder arthritis, the pathoanatomy is anterior contracture or anterior capsule undergoes tightness. So these patients are also present with loss of external rotation at the outset. But what you need to look for is to get a 2AP view on X-rays, and that will allow you to find out that yes, we are probably looking at a primary arthritis rather than looking at a frozen shoulder. And that is the only role of X-rays when you're doing imaging for frozen shoulder. Frozen shoulder is primarily a clinical diagnosis. You're doing an X-ray not to confirm your clinical diagnosis, but to rule out other scenarios which may be missed. So let's say we're looking at these 2 patients here. absolutely identical range of motion. The lady on the right is coming up to probably 0 to 90 in spite of scapulothoracic, and likewise the gentleman on the left is coming to 0 to 90. But when I'm looking at the passive range, you see the lady on the right still can't go beyond 90 to 100 degrees. As opposed to that, the gentleman on the left can actually go up to nearly 0 to 160 degrees. So it's straightforward that the lady is suffering from probably a frozen shoulder, and the gentleman is probably suffering from a cuff tear, so, or a neurological condition, because his rotator cuff is not firing. That is what is important. So what Codman had first described frozen.
Sir, please unmute yourself. Nilesh, sir.
Sir, we can't hear you.
Hello, sir. Kamath, sir.
Is this better?
Yes, sir.
Yeah.
Now.
So you've not heard me right from the start?
No, sir. Just 2 slides back.
Okay.
After the video one.
So did you see the video?
Yes, sir.
The next one, sir.
Fine. All right. Sorry. Okay. So if you look at what Codman had mentioned back in 1980s was that, in 1890s, is that he had described this entity as difficult to define, difficult to treat, and difficult to explain. And nearly a century down the line, we are still in the same scenario where we still can't define it. We still find it difficult to explain it to the patient, and we still find it difficult to treat. Clinical presentation, well, all of us are aware about this, that it's a painful, limited range of motion characterized by night pain. But you would say that the same things are also present in a rotator cuff tear. Then how do we differentiate? 2 main things: your rotations, especially your external rotation, there is a disproportionate restriction to such an extent that if I have a patient who is not having loss of external rotation or internal rotation, I would not label him as a frozen shoulder. I would really be worried about calling him as a frozen shoulder. And the second thing which stands out is jerky pain when there is a sudden movement, and that's an excruciating pain. For me, these 2 things really stand out. Getting your X-rays, getting your MRI, these are all secondary things. But primarily, when I see a patient on history and on clinical examination, you should clinch a diagnosis that you're probably looking at a frozen shoulder. What is the pathoanatomy? It is the coracohumeral ligament, which is a part of the rotator interval. Now, why is this important? See, all patients nowadays, more or less, I would say 60 to 70% of your patients will be having an MRI with them. So even when you look at the MRI, and if you see a hyperintense signal in the rotator interval, and what is the rotator interval? It is that space above the subscapularis on the coronal pictures. So if you see a hyperintense signal on the MRI, then you should think about early adhesive capsulitis or a frozen shoulder or a periarthritis shoulder, because these are all interchangeable terms. So that's the first thing. Even before having loss of rotations, patients will present with this. And this is a typical pattern. Your pain and stiffness don't go hand in hand. When patients first present to the outpatients, they present with pain. And you'll see that the pain tends, of course, this is a pictorial depiction. It's not necessary everyone is going to follow the same pattern. But by 6 months, your pain is maximum. And then by 12 months, as the pain is on the decline, your stiffness is going to be progressive. And that's going to practically resolve by nearly 1.5 to 2 years. And that is where your Reeves stages come into picture. You have 3 classical phases: your acute painful stage, or the frozen stage, or the thawing phase. Majority of the patients will come in one of these phases. It's very difficult to demarcate that which one is what phase, because there is a significant overlap between 2 phases. What I follow in clinical practice is, in the painful stage, the night pain and the jerky pain will remain. So the first target is to reduce that, because in the frozen stage, patients will not have night pain and jerky pain. And that's where I need I would need the help of guys like you who can really push that patient, because the inflammation is settled down. He's in the frozen phase. It's only a time capsule and you want to stretch the collagen. The thawing phase, well, as it is, the patient is literally going to come back to normal whether he sees either one of us, right? So no intervention is normally required in thawing phase. The enigma is when you look at treatment options, there is literature which is so abundant on whether you're looking at physio, whether you're looking at NSAIDs, injections, manipulations, bristment, whether to do a release, and so on and so forth. Quickly, I'll touch one of them, each one of them, and then we go on to Sania's talk. Whatever I'll be talking has to be backed up by evidence. It is not just because I'm feeling so. We need to practice what is evidence-based science, and that's exactly what we're trying to do here. So how important is physical therapy for adhesive capsulitis? It is said that it is, and this is Cochrane database, which talks about physio being extremely important, but it needs to be in conjunction with something else. That means if you're only wanting to do physio, and if the patient is painful, he may not get as much benefit. In those cases, if you were to consider a concomitant steroid injection, and when you're talking about a steroid injection, either it could be a glenohumeral or subacromial injection, but that's something which may be beneficial for the patient and it would give you a faster result. So when do you and where do you inject these patients with a cortisone? If a patient is reasonably comfortable and can manage his pain, I don't inject them. But if a patient says that the night pain is bad enough, is unable to sit or unable to sleep through the entire night, is non-compliant with physio because there is pain, in those scenarios, I offer them an injection. Also, you need to be sure that your blood sugar levels are absolutely within control, and there is everything else which is ruled out. For example, what I mean here is I'd seen this patient who had a low-grade septic shoulder. The treating clinician had labeled him as a frozen shoulder, and he injected him with a corticosteroid. And that was a recipe for disaster, because this guy came to us with complete septicemia. And the cuff was all eaten up, and all we could do was arthroscopic debridement, but the functional outcome would always be poor because the cuff was eaten up because of the infection. So getting your patients right and selecting them right is very, very important. So if you're deciding on injection, would you like to do a subacromial or would you like to do a glenohumeral? This is another common point which is asked. Now, and for those who would be a little confused about it, let's look at the shoulder joint as a two-story joint. It's like a duplay. Your ground floor is going to be your glenohumeral joint. The ceiling of the ground floor is going to be your rotator cuff or your supraspinatus. And the first floor is going to be your subacromial space, the ceiling of which is going to be your acromion. So if I have to stack them up from above down, you have the acromion as the ceiling of the first floor. You have the rotator cuff, which is the floor of the first floor and the ceiling of the ground floor. And you have the inferior capsule, which is, of course, the floor of the ground floor. So you need to think whether you're going to inject in the ground floor or in the first floor. That is what you need to look at. What evidence states is that if you inject in the glenohumeral space, that means in the ground floor, the results are going to be faster. But does that mean that a subacromial injection is not as effective? No. In long-term studies, the efficacy has been proven to be more or less equivalent. Then what is the difference? Why would you prefer, or at least let's say, why would I prefer a subacromial injection? Because as it is, the capsule is contracted. The chances of you hitting the narrow glenohumeral space is going to be much lesser. Even in the best of hands, if let's say 10 shoulder surgeons would try to inject the glenohumeral space without doing an ultrasound, the chances of the drug going outside the joint is as high as 70%. Then does that mean that you do an ultrasound guided injection? Unfortunately, in a country like India where everything is cost driven, you can't add the cost of another investigation, which the patient is never going to be happy, because we also know that even after the injection, it's not as if there is instant pain relief. It does take some time. So what evidence says is that in the long run, it does not make a difference whether you inject in the glenohumeral space or whether you inject in the subacromial space. Would you like to prefer doing a manipulation? It's a very personal choice. I personally don't like manipulation simply because it's an uncontrolled force. But having said that, literature does not make it obsolete. So there are some surgeons who do believe in manipulation. You just need to be careful that you don't land up with a fracture of the proximal humerus, or you don't land up with a brachial plexus injury or a rotator cuff tear. Again, the outcome of manipulation under general anesthesia in diabetes. So it has been proven that diabetic patients are probably the most difficult patients to manage when you're looking at frozen shoulder. And these are a good subset of patients who, if they are not responding to conservative treatment, you may think about doing a manipulation. And whenever you're doing a manipulation, it would make sense to inject the joint as well in the same sitting. Now, before going on to arthroscopic release, what about capsular dilatation? This is again something which is very commonly discussed in the outpatients, that how many times do we do a capsular dilatation? I'm going to show you a video of an arthroscopic release, and you will realize that the capsule is so thick that for those who are not aware, what is brisement? In brisement, you inject or you insert an 18 gauge needle into the glenohumeral joint. You simply take normal saline in a 20 cc or a 50 cc syringe, and you try to keep pushing it as much as possible, and the pressure from inside tries to distend the capsule, and it is believed that that will stretch the collagen, and that stretching of the collagen will break the adhesions. This is something which has been described in theory, but if you were to look at your capsule, so I'm going to go forward. The capsule is so thick in these patients that even when we do an arthroscopic release, it's a big challenge to go through the thickness of the capsule. So I find it very difficult and challenging to believe that just brisement by itself will give you as much relief. Also, if you look at literature, not a single surgeon would just do brisement. They would do brisement followed by manipulation. So effectively, if you're looking at manipulation, well, that is a well-proven technique, but a brisement by itself, it has to be in conjunction with a manipulation. If you're doing an arthroscopic release, there are two window periods where you can do it. One window period is very early on, where patient is actually in the inflammatory stage, he wants to get back to function faster, where you can do an arthroscopic release and allow that capsule not to tighten up. Or the second phase or second window period is towards the place where the natural history is kind of arrested. That means he's in the frozen phase, is doing physio. 4 to 6 months of physio has not helped and he's not progressed further. That is when probably I might be thinking about doing an arthroscopic release. How do you an arthroscopic release? So we'll go to the video actually. So you're looking, your patient is in a lateral position. Your humeral head is what you can see. I hope you can. I've not yet played the video, but can you see the picture, Sania? Yeah, okay. So you have the humeral head, which is sitting on the glenoid. So what curvilinear structure you can see on the top is your humeral head, and what white color structure you can see below is your glenoid. So you can see the first thing. Now you can see another structure which is probably running from 7 o'clock to 2 o'clock position. And that is your tendon of subscapularis. And above the tendon of subscapularis, you have the rotator interval, which is your coracohumeral ligament and your anterior capsule. Now look at this rotator interval, how inflamed this is. You can imagine the amount of pain this patient must have been in. That entire rotator interval is crazy red. It's like cherry red. The first thing you would want to do is do a rotator interval release, because you are going to get an external rotation movement. So that's the radio frequency coming in, and you're starting to release the entire rotator interval. And what I would want you to pay attention is the thickness of the capsule. See how thick that capsule is. So to believe that only by brisement that entire capsule is going to undergo distension, it is wishful thinking, I feel. Then you go ahead and you do an anterior capsular release. And again, pay attention to the kind of synovitis this patient has. You're moving away from the articular cartilage, and with the radiofrequency probe, you're simply letting the capsule spread out. So you're not going to go right till 6 o'clock position because that's where the axillary nerve is going to come in. So likewise, viewing from superior, you're then going to release the posterior capsule. And trust me, it's a nightmare because that joint is so stiff that to maneuver your instruments out there is not as easy as it seems. Probably that's also one of the reasons why all arthroscopists keep their indications very limited. When do they want to do an arthroscopic release rather than doing it as a first choice technique? So you can see the thickness of the capsule, a thick capsule, probably more than 4 to 5 millimeters. And that's when you start seeing the fibers of infraspinatus because we are doing it on the posterior aspect. Once you have done this, that little bit of inferior part near the axillary pouch, you have to do it or release it by manipulation. So long-term outcomes, well, they have shown that there is a better range in motion, pain frequency reduces, and the total severity and function of the patient comes back to normal faster. So what works better? If I have to put it in a nutshell, if you have decided to go beyond conservative treatment, either a manipulation or an arthroscopic release, results are more or less equivocal, slightly more in favor of manipulation. But understand this is data from back right from 1980s, 1990s to your 2010, 2020. You don't have a high quality study which is probably only 2010 to 2020 or 2015 to 2020 to really demarcate that. So if you look at the natural history, this is the longest study possible, a 2 to 27-year-old follow-up. I mean, that's crazy to follow up a patient for 27 years. And what the authors had to say is that 94% of patients with spontaneous frozen shoulders will return back to normal function and normal motion, irrespective whether they take treatment or they don't take treatment. So rightly said, in the 17th century, it was said that the role of the physician is just to entertain the patient while the disease runs its normal course. And it's not unusual that you will go to Dr. A, he's not happy with the results, he'll go to Dr. B, Dr. C, Dr. D. By the time he reaches, say, X or Y, automatically it's going to run through its normal course. And for him, suddenly that doctor becomes like God status. But that's not what it is. You need to understand that that's how frozen shoulder would believe. This is how I would probably look at my options. If I'm seeing a patient with a frozen shoulder, after the patient is pain-free, I would probably think about doing a motion restoring exercise, including mobilization. If that is not helping, then probably a manipulation. If that is not helping, a steroid injection, a MUGA and surgery is really a very rare indication. If we see around 200 or probably more than as many shoulders in a calendar year, probably one or two will land up on the operating table and all of the other patients will settle down only with medication and with some amount, a good amount of physiotherapy, but that is what is required, right? Thanks so much. So what we'll also do is to maintain the continuity. I don't know if Nikita is here. So Nikita will take over. Nikita, I'll do stop sharing of screen.
Yes, sure. So here we got the perspective of the surgeon also. So the amount of cases or amount of the experiences you've had with frozen shoulder and with dealing the frozen shoulder with your surgical approaches does give does increase the horizon for our thinking to actually see that what exactly we perceive when the patient comes to us with so much of pain and so much of irritation with the pain, and whatever we try to mobilize or try to move the joint, and it is so hard for us to even get a degree or maybe 10 degrees to even move. So now coming to the physiotherapy point of view for a frozen shoulder, I'm inviting Dr. Sania Pathak. She's our physiotherapist at Sancheti Institute of Orthopaedics and Research. She specializes, or she's more inclined towards shoulder conditions. So, getting on her academic background, she's been a topper in her undergraduate degree, from which she completed from Maharashtra University of Health Sciences and from our very own college, Sancheti College of Physiotherapy. She completed her master's degree from Rajiv Gandhi University of Health Sciences, Bangalore. Over to you, Sanya.
Thanks, Nikita. And I would also like to thank Sir for such a clear yet simple explanation about the condition, because that is very necessary when we are talking about the rehabilitation part of the frozen shoulder person. I'll just share my PPT. Just give me 1 minute. Yeah. Can you see that? Okay. So we are talking about frozen shoulder busting the myths. So let me just continue the discussion. Now, frozen shoulder or adhesive capsulitis. So both the terms are more commonly used interchangeably. We feel that it's the same, but if we go through the literature, frozen shoulder is of idiopathic etiology. So the etiology is unknown, and it presents as global restriction in the range of movement. All the possible ranges, more severe restriction in external rotation, which we think or which we see as a capsular pattern. So external rotation, abduction, and internal rotation. Internal rotation will it is the first to go and last to come, as we all know. And it is very painful at onset, as Sir has already explained. And we can see the normal plain X-ray film. So that is like just to rule out all other possible conditions or the diagnosis. Adhesive is the term, the literature says the term is inaccurate because this condition does not present with adhesions per se. So rather it is related to synovitis and progressive contracture of the capsule. So I'll just briefly talk about pathophysiology. Basically, as Sir has explained it very well about the rotata interval. Why it is important to understand about rotata interval is because when you are talking about ranges, or when you are talking about progression of the exercises, or whenever you want to improve the range of motion in a patient, you have to understand which structures are tight and when to stretch those structures. So involvement of the rotata interval is very, very important because it begins with the thickening of coracohumeral ligament, which usually restricts your external rotation. Now, rehabilitation depends on the 3 stages, freezing, frozen, and thawing. The protocol or the pattern what we follow changes according to the patient presents to us. So the first stage, freezing stage or painful stage we call it, usually we all use all the pain relieving modalities which will control the patient's pain. Okay, so you can use either heat or cold. There is no thumb rule or there is no fixed protocol. Either we should use heat or cold. Obviously, now we all are practicing physiotherapists, so we know in the initial stages, patient complains of pain because of spasm. So whenever you want to reduce the spasm, heat is always better. If patient is oversensitive and patient cannot tolerate heat, or there is a active inflammation going on, so you do not want to progress with the inflammation, you want to reduce the inflammation, so cold or ice packs are much better for the condition. Ultrasound is also helpful. Various studies are there. I guess Nikita would be able to tell us better about the studies, the recent advances, with what frequency and how much duration we should use. But ultrasound, it basically helps in reducing the inflammation around the shoulder joint. That's why reduction in pain. Also, IFT, whenever the patient is presented with trigger points in say rhomboids or upper trapezius, so IFT helps relieve the spasm. Taping is very useful because taping basically aids in correcting the posture and thereby relieving the pain. So kinesio taping, I practice a lot, and I am getting good results with taping. The aim should be to maintain the range of motion and not to stretch it to the pain threshold. So always you should remember that we should not reach patients' pain threshold, or we should not cross that, because if you do that, basically you are going to add to more inflammation, which will worsen the condition, and the initial first phase is just going to prolong. So basically you are not doing any good to the patient, you are just worsening the condition. So you don't want to do that. Pendulum exercises are also called as Codman's exercises, but it has to be done in a correct technique, because pendulum exercises, we feel that patient just has to move the shoulder in a pendulum manner. That is not right, because by doing it in a wrong technique, you are just causing scapular dyskinesia and adding more pain and dysfunction to the patient. So that should be taught correctly to the patient. Yeah, I have pictures. So what is right and what is wrong? So I'll just go through the next two stages and I'll come to the pictures. Second stage is frozen stage. So you start, the pain has already gone, as sir has described, night pain is not there now. So you can start with gentle stretching. You can start with mobilization. So there are like the two options: soft tissue mobilization and joint mobilization. You have to work on both, because of the active inflammation which has maybe lasted for say 2 to 3 months or 3 to 6 months. Obviously the patient hasn't moved the shoulder, so there is going to be soft tissue restriction as well as joint restriction. Sorry. So soft tissue mobilizations, MFR or MET, muscle energy techniques, it works very nice. And for joint mobilization, you can use any of the mobilization techniques, say Mulligan, Maitland, Carlton bone. MWM works very good. But you have to remember, as well as you are moving the glenohumeral joint, don't forget to target your sternoclavicular and acromioclavicular joint, because shoulder is frozen shoulder. We always think, okay, it's glenohumeral joint, but it works, it is a unit. So you have to also address SA and AC joint along with scapular mobilization. So do not forget scapulothoracic joint as well, because if you keep on only working on glenohumeral joint, you will not attain the proper biomechanics and patient's pain will not go. Especially if you want to achieve overhead flexion or like overhead movements, you have to see the AC joint mobility, which is commonly restricted. So once you mobilize the AC joint, you get good results. Also, because of the long-standing pain, there have been changes in the patient's posture. So patients usually present to you with forward head and protracted shoulders. So that also contributes to loss of flexion and abduction, because you need good torso so that the patient's upper limb mobility can be achieved properly. And also you can start strengthening in the available range. So I prefer going with eccentric control training and isometrics just for the maintenance of strength, not going very vigorous or very aggressive with the strengthening part, as again, two reasons: I do not want to cause more inflammation, and second, I do not want to develop any tightness or reflex spasm or guarding. Third is the thawing stage, relatively safe stage. You have to start capsular stretches with that. Now we have talked external rotation is restricted in the frozen shoulder because of the rotator interval involvement. So you have to start stretching the anterior capsule, and otherwise you will not get your external rotation complete. While doing that, you have to keep all the structures in the mind. For example, inferior glenohumeral joint ligament, because that basically superimposes the capsule. Also coracohumeral ligament and medial glenohumeral ligament. Your medial glenohumeral ligament, it restricts the external rotation when your shoulder is below 90 degrees, so usually 90 to 60 degrees. And if at 90 degrees, your inferior glenohumeral ligament is the restraint to the external rotation. So keeping that in mind, whenever you are taking the shoulder in say some degrees of abduction, or you are keeping the shoulder by the side and just doing the external rotation, the respective structure you want to stretch, you have to keep that in mind and then work accordingly. In this phase, progression of strengthening exercises. So TheraBand exercises are always better over free weights, because TheraBand is an elastic resistance. It provides you the elasticity. So for concentric activation of the muscle as well as eccentric activation of the muscles. So with TheraBand, you can achieve good results. And very, very, very important, focus on normal scapulohumeral rhythm. So even though you have good range, but if by this time, say 6 months to 8 months, patient has forgotten about the scapulohumeral rhythm, So you really have to train the patient. You have to introduce proprioceptive exercises so that patient understands what movement he is performing and what exactly is the correct pattern of the movement. Otherwise, in spite of having complete range of motion, in spite of having complete or full, you can say grade 5 on 5, patient might still complain that whenever I lift my hand or in certain positions while doing certain activities, I still have pain. The reason being the scapulohumeral rhythm is not right. So you have to correct that as well. Okay, so now these are some pictures how to do the exercises. So there are very small you can say techniques, or very small points which you should keep in mind so that you attain your goal without causing pain to the patient. So for example, the first image you can see, the patient is lying down properly. Wand exercises, you can like which we give in the initial phases or the frozen phase as well, just to stretch, active assisted exercises. Now in second image, what you can see is you feel that the range of the shoulder flexion is increased, but look at all the compensatory movements the patient is doing. Look at the lumbar lordosis, the scapula is not stabilized properly. So you might feel that whatever you are doing is adding to the range, but you also have to see whether the patient is doing any trick movements or no. You have to be very vigilant about it. Second, whenever we want to try abduction with the wand exercise, so usual mistake what happens is patient holds the stick in both the hands or whatever, the paper roll or the wand, and he just take it out. Even some therapists are not clear about the technique. So what in the wrong picture, the which is on the right hand side, what is happening is basically the humerus is an internal rotation, and the more you are going to take it into abduction, you are just going to cause impingement, and obviously patient is going to complain of pain. But we feel that yes, pain is bound to happen, so we just try to push it, but it is wrong. Simply doing the external rotation and then asking the patient to perform abduction is the correct pattern which we all should practice. Next, ideally we all should initiate abduction or any position in scaption rather than pure abduction, because scaption is the functional movement. In abduction, again we have talked about the tightness of the anterior capsule, so complete abduction will not be possible to the patient and it will be very painful. So scaption, all the muscles are relaxed. Scapular stabilization is good because the patient is in supine. Patient is getting the feedback of what he is doing. And then first you attain complete range of motion in scaption. Simultaneously, you work on your soft tissue mobilization. So you are releasing the capsule, you are releasing the muscles. So then you can progress on to performing complete abduction in like the proper abduction after the scaption range is complete. Okay. Now, external rotation, usually what patients do is they just do it in sitting or standing without any stabilization of the humerus. So what can go wrong in this is they just try to rotate from the trunk and they feel again that the hand is going out, the hand is moving. It is not right because the actual glenohumeral movement is not happening. So I always prefer giving the external rotation in supine for the avoidance of compensatory movements. Also support the arm properly, because otherwise what happens if you do not support the arm properly, you are keeping the elbow down, so there is again going to be a lot of stress on the anterior structures of the glenohumeral joint, which will again cause pain and patient will not be compliant to your exercises. Another trick movement what patient can perform in this is you can see it in the next image. Patient can extend the elbow, and again it might look as if the patient is actually doing external rotation, but the movement is happening from the triceps or it is from the elbow. Patient is not rotating the humerus. So whenever the patient is performing this, you should feel for the external rotation, you should feel for the end feel. You will come to know whether the movement is proper or no. And wall slides, commonly given as home exercise program, but this is what patients do. Patients suppose left side affection, so they will try to reach as high as possible, but with all the compensatory movement. So to prevent that, simply you can just give bilateral hand movement, so lateral trunk lean or any other, whatever the patient is doing, that can be prevented, and then patient can practice it and patient can report the actual ranges to you the next time. So this is just a simple graph about pain versus movement. I have got it from an article which is showing how with time the pain intensity reduces and your movement improves. So our take home messages will be myth, as the heading is saying, as our today's topic of discussion. So myth 1 is what frozen shoulder and adhesive capsulitis are same. It is not same. The correct term would be frozen shoulder. Second myth would be vigorous mobilization is required to treat the condition. It is not true. Please keep that in mind, because as sir said, if we start mobilizing or if we start stretching exercises in the early initial phases, acute phases, which is inflammatory, we are just going to cause more and more inflammation. The pain is going to increase and patient's condition will worsen, which we do not want. So correct timing and intensity of the mobilizations for optimum recovery from the condition is very, very important. And third is pain with movement is normal. No, it is not normal. So please respect patient's pain. Be empathetic. Patient education in this condition is very important. You have to educate the patient that yes, this is going to take some time. With rehab and with exercises, basically what you are going to do is you are going to reduce your suffering from the condition. You are going to reduce your pain and maybe you can accelerate the healing process. But that X amount of time the condition is going to take. So you have to prepare the patient for that. That is very important. Thank you. I would like to ask Nikita if she wants to add anything on this.
Sonia, if I can just interrupt in for a second.
Yes, sir.
Just put on your take-home slide, and I think that is pretty much the gist of this meeting, right? I mean, what Sania has mentioned here is clearing the myths, right? This is exactly what I would like to emphasize and re-emphasize. These 3 points are very, very, very important, right? Probably first one is just regarding nomenclature. So just again, to talk about evidence-based, ISACOS, that is the International Surgeon Society of Arthroscopy, knee surgery, and sports medicine, they have now made the term adhesive capsulitis obsolete.
Yes.
Right? So even on your OPD charts, if you want to write, the ideal way to chart the patient is, if, for example, I have a patient who's come in the inflammatory phase, I would write my diagnosis as frozen shoulder, in bracket, inflammatory phase. Or if he's in the thawing phase, I'll write frozen shoulder, thawing phase. See, because the diagnosis of frozen shoulder is going to last as much as 1.5 to 2 years. So I can't really keep on writing frozen shoulder, frozen shoulder, frozen shoulder. That's one thing. I think second point is really a take home for all the orthopedic surgeons and all the physiotherapists who are a part of the fraternity here. Because we need to understand that we've had patients coming with tears in the eye and relatives getting upset and anxious that physio has started and there's so much of pain. Also, stop telling the patients that if you don't do physio, you lose out on movement. Well, they are going to lose out on movement. That's the natural history. But also after losing out on movement, they're going to regain that movement.
Yes.
So staying within that movement is very important, that maintaining movement rather than trying to gain movement. I think that's an excellent take home point. And the last point couldn't have been emphasized more: respect the patient's pain. Going back to our physiology days, all of us have learned physiology. The first line in your function of pain was pain is a protective phenomenon. So if the body is giving pain, it's trying to tell you don't do this, right? You will not have a single stimulus which is without pain if it is not harmful to you. You put your hand in fire, you get pain because it is not good for you. So if there is pain and if you're trying to overcome that pain, that's not right. You need to be within the pain free. Some stretch discomfort is okay. You would discuss that then post-op when you're trying to get range of motion, patients are less on pain threshold and so on and so forth. Yes, we do understand that. But by and large, patients' pain should not worsen. That is what is the take home. So I think, Sania, kudos to you to just put this all in one slide, because this really drives home the point over and over again. Thank you so much.
Thank you, sir. Thank you so much.
Yes, sir, that's true. So coming back to the same thing, as we were talking about the pain right now. So as Dr. Kamath told, that when there is pain, it is actually telling us something, that something is not right in the joint. So maybe as physios, we take it for granted that yes, patient is going to come to you with pain, so I am going to treat the pain, but movement is important as well. So coming to the our first myth, that our myth which Sania pointed out, that yes, pain is not normal. We are supposed to respect the patient's pain, because with that pain, the patient will not be able to do most of his ADLs or the activities of his daily living. So, so normally, sir, Dr. Kamath, it's a question to you. Generally, a patient comes to us with a frozen shoulder, especially they come to you first and you refer us. They come to us with a frozen shoulder, and they have immense amount of pain. They are not able to do their actual movements, like normal movements, which they cannot do their hair, they cannot wear their shirt properly, and most of the time I guess even the patients miss out the freezing phase of their frozen shoulder, which we normally expect that they would experience a lot of pain. And especially the current Indian tendency is that yes, I have pain, but ठीक है, 2 दिन में ठीक हो जाएगा. I'll take some painkillers and maybe it'll be fine after a week or so. So whenever they are coming to you in a freezing stage, so what is your whole idea about giving them the rest, especially the joint, giving their joint some rest, or you want to start with the movements immediately?
So I'm very clear on this, that, and Sania would agree to that, that I don't send my patients for physio from exercise perspective, from mobilization perspective, till the night pain and till the jerky pain is not abolished. Till then, the patient is not going to see Sania. It's period. Yes, he might see Sania for modality. You could do modality to reduce the pain, to reduce the discomfort, but we are not going to work on getting his range back. Also, the other thing in the same breath I would mention is that one of the other myths is that use painkillers so that the pain goes down. Well, again, evidence-based non-steroidal anti-inflammatory drugs do not alter the natural cause or the natural history of the disease. So you want to use them on an SOS basis, that's still good enough. But do not use them. I've seen patients like taking it for 4 weeks, 6 weeks, 8 weeks. Doesn't make sense, because it's anyways not going to change your natural history. Give them something like paracetamol, give them something like tramadol, which is not going to have any nephrotoxic effect. So that's a much safer bet. And ask them to take this, if you're mobilizing them, ask them to take this a good hour before they come and see you, so that they are more compliant with exercises rather than getting them through the pain part of it, right? But it's not going to change the natural history.
Yes, sir. So mostly, even as physios, if I am getting a patient or I fix an appointment with a patient saying that I want you to be here by 10, so we miss out on the point that we also have to ask their pharmacological management there, that what time do they take their painkillers, or what exactly would be the half time of the painkillers that I can act on when I'm giving a mobilization, or when I can progress with their resistive exercises. So going back to Sanya, what do you expect, Sanya? So you want them to have a proper rest period, then come back to you, or you want to give them some stretches and maybe continue with their activities and then get back to you after a week's time or so?
No, actually, I guess sir has already answered, because it is very, very important to manage their pain. Patients do come to the OPD only for pain relieving purpose. So we can just give them, as I had already mentioned, just maintenance of the range. That's all they have to do. In that also, they might not succeed as they can think, because the condition is such that they are bound to have that stiffness. But as far as possible, they have to maintain the range, and the pain has to go down, as the ninth pain is not there. So then patient is referred to physiotherapy, and with following this, we are actually seeing a lot of shoulders getting better. SIRS patient only. So it's actually working for the patient. So even I don't support going aggressive with the exercises in the initial phases.
Okay. So, Kamath, I have the next question to you. So,
Yes.
if you already told that you seldom do the hydrodilation or the breast mint, whatever you were talking about. So,
Right.
even if you're going ahead with it, even if you do it for a patient, what would be your idea, or how do you want the physiotherapist to take over later?
So if you're doing any intervention, let it be breastment, let it be capsular release, let it be manipulation, then you have a very short window period to go very aggressive with rehab. And in those scenarios, you need to top up the patient with as many analgesics as possible and try to get them to mobilize the shoulder. Because if you don't do that, see, by doing a bristment or a manipulation, what are you going to do? You're going to break open the capsule, right? So if you're breaking open the capsule, you have two raw surfaces which are staying away from each other. Now, if you don't mobilize this and you ask the patient to rest, these raw surfaces are again going to come in contact with each other, and they will land up with a stiffer shoulder. So if you're doing an intervention, go all guns blazing. Then you ask your clinician that you do whatever pain management it is, but get the patient as pain free as possible. Only then can I get the shoulder to move. But yes, then you can't sit on it that you will wait for the patient to become pain free. You have to mobilize the patient.
Yes, sir. So again, we are supposed to be in accordance with our surgeons or whoever is referring the patients to us. So again, coming to the same notion, do you
Sorry,
want?
I'm going to interrupt again. I'm going to interrupt again. It's, it's the biggest myth in India that physiotherapists need to follow their surgeons. And I would put this in a public forum. I'll put this in print if required. I think you guys spend more time with the patient than what the surgeon spends. We probably have a 5 to 10 minute window period where we would spend time and we would examine the patient, as opposed to that you would spend in more time. And there's no shame in going by what your clinical findings are. And you, if you kind of call up and tell us that there's something which is wrong at our end, there's absolutely no shame. At least, again, I can speak for myself. Tomorrow, if Sania calls me and tells me that I don't think this patient has a frozen shoulder and I think that we are missing out on something, I think with all humility, it's up to me to accept that, to probably reassess the patient. If I have studied my subject, even you have studied your subject. It's just an unfortunate trend in India that physios need to follow what the surgeon says or what is written. No, I think you can just take this by yourself. You guys are all good enough for that, right?
Yes, sir.
So
So
I am lucky with that, because I can directly go to sir and talk about patients. But yes, this has to be there. The actual, what you can say, you that approach, you should be able to approach the consultant surgeon. That is very important, and it should be regarding patient's betterment. So then that's how we can work.
Agreed. I completely agree on that.
So again, going to the next question, we have established that uh, there is no as such adhesions that are present in the capsule, considering the adhesive capsulitis part of it. So frozen shoulder is always been an umbrella term. So even while discussing with Kamath sir also, he told the same thing, that any patients which you were getting earlier was always considered a shoulder pain patient. Any patient you were getting earlier was considered a frozen shoulder. So very rarely it was diagnosed as a rotator cuff or a bicipital tendinopathy or a supraspinatus tendinopathy. So again, we did bust that myth today, saying that frozen shoulder is much more acceptable scientifically, because as such, even whenever you're going into the surgical approach to the shoulder itself, there are as such no adhesions present in the capsule. Yes, there might be a capsule thickening, as sir said, but as such adhesions are really not possible. Any ideas, Dr. Kamath?
Sorry, I just, your voice was breaking. Sorry, I'm going to ask you to repeat that question.
Sure, sir, no issues. So basically, we busted the myth saying that adhesive capsulitis is not necessarily a scientific term, and it would be a
Yes.
misnomer if we are going to use it for a frozen shoulder. So
Right.
as you already you were saying while discussing the other day, that very rarely, even as a resident, you would actually diagnose a person as a frozen shoulder. So our differential diagnosis of the shoulder itself is quite vague even now. So do you want to throw a light on the same?
So frozen shoulder, according to me, is a clinical diagnosis. It's something which typically on history and on clinical examination, you should clinch the diagnosis. Now, when you're labeling a patient as frozen shoulder, before labeling him as a frozen shoulder, just see to it that you don't miss out on other things. And what are the other things? As I mentioned, commonest thing here is probably looking at a glenohumeral arthritis, because a glenohumeral arthritis will present like this. And if you were to ask me any other thing which really comes to mind, it's avascular necrosis of the humeral head. Because when there is a subtle collapse and the patient is not getting that movement, these patients go from pillar to post just being treated as frozen shoulder. Now, in these cases, you need to be very careful about how much mobilization you do, because the more forceful mobilization you're going to do, the further it is going to bring about a subchondral collapse. So you need to maintain that fine balance. And that is the reason why X-rays are required, or if patient is affording an MRI is required to rule out that you're not looking at other pathologies. So from differential perspective, I would keep osteoarthritis, avascular necrosis, I would keep any form of glenohumeral arthritis. These are my predominant differential diagnoses if I'm looking at frozen shoulder.
Yes, sir. So again, whenever we are going about an examination of the patient or assessment of the patient, it's better that we have a proper differential diagnosis done as well. So we could rule out any other conditions which are normally present in the shoulder joint. So coming to you again, currently we have a lot of patients coming up with hypertension, diabetes, even thyroid issues for that matter. So, how do you think these lifestyle diseases are going to affect our prognosis for the frozen shoulder itself?
So there is a distinct correlation. All of us would agree on that, that when it comes to lifestyle disorders, I think thyroid and diabetes are the commonest conditions where there is some amount of hormonal imbalance. It is probably these are the two commonest situations which are associated with frozen shoulder. Also, what we have seen, and we are trying to write this up, what we have seen is even amongst diabetics, it's either a pre-diabetic, so someone who's probably having a glycosylated hemoglobin of say 5.9, 6.2, or probably someone who's an uncontrolled diabetic. The ones who are in reasonably good control, they don't easily land up with a frozen shoulder until and unless there is an antecedent history of a sudden jerky movement, like trying to lift up a shutter or trying to throw a stone or something on those lines, where there is a capsular stretch which has taken place and that triggers off a frozen shoulder. But by and large, it's these pre-diabetics or uncontrolled diabetics, or these thyroid patients who land up with frozen shoulders. These are the main two things. Of course, the list is endless, because if you look at any systemic inflammatory arthritis, they can land up with frozen shoulder. But offhand, if you would say clinical practice, which are the two most common things? I would put thyroid and diabetes.
So I'm going to ask Sanya her point of view here. So Sanya, you might have encountered patients with or without diabetes coming to you with frozen shoulder. So not only diabetes, as Sir said, it can be any thyroid hyper or hypothyroidism that is going to cause quite an amount of systemic or hormonal changes that is going to affect the pain as well. So according to you, which one is easier to treat with, or which is better to treat their symptoms?
Uh, yeah. So basically, patients with diabetes or thyroid or any endocrine dysfunction, you can say, the prognosis is not as good as you would find it with other patients who are non-diabetic or who doesn't have any endocrine disorder. So basically, what happens is, suppose we are talking about diabetes, the ranges, or what you can say, the graph, basically, it changes. So one day the patient is better if the patient is stressed and if the BSL is high. So again, you might have increase in their pain, or you might just lose on some range. So that takes really that is taking the time in the rehabilitation process. Otherwise, what you can say, the protocol per se does not change, but every day you may encounter some different complaint, and their complaints do not go easily. So their pain is constant. Suppose a normal patient, if there is pain reduction from say 7 on 10 to say 3 on 10, a diabetic patient might not give you that much pain reduction. So that's why the prognosis is, I won't call it poor, but it definitely takes more time.
Yeah, so that is again, it is going to be more than maybe 9 patients out of 10 that we are going to find with some of the other comorbidities. Again, it's a lifestyle disorder.
Uh, yeah. Also, I want to add, if patient is like, if he presents with hyperlipidemia or say alcoholism, any condition which will cause your body inflammation to rise, that condition is going to hamper the rehabilitation process. So it's not only diabetes or thyroid, any condition which is causing more inflammation in the body.
Yes, Dr. Zania. So again, we would have to be careful. We are going to have to be in contact with the patient, asking about their pain or any small activity which they were not able to do yesterday and they're able to do today. So even keeping a check on their progress on their personal life wise is also important as a physiotherapist. So coming back to my next question, sir, it is to Dr. Kamath. So we very rarely, as according to you, we very rarely do any arthroplasty for the shoulder joint itself. Again, considering the frozen shoulder being one of the causes for the arthroplasty, we would rarely do it. But even if I want to, or I would have to refer, or you would have to do an arthroplasty for a shoulder patient, what would be your guidance for the physiotherapists?
Like you rightly said, arthroplasty is never treatment of choice for a classical frozen shoulder because the articular cartilage per se is never affected, right? So we would not even look at this as a treatment option when it comes to an idiopathic frozen shoulder. Now let's talk about a secondary stiff shoulder. What I had shown in my talk earlier. So if I'm looking at an inflammatory condition, and if the rotator cuff is good, right? Even if there is tendinosis, and if the rotator cuff is good, and if the patient is young, demanding, I would do a total shoulder. As opposed to that, and that is only when the articular cartilage is destroyed because of the inflammation. Remember, whenever the articular cartilage is normal, whatever the cause or whatever the condition is, you will not do an arthroplasty. Arthroplasty comes into picture only when the articular cartilage is affected, whether it is primary arthritis or a secondary arthritis. So here, if you're looking at a secondary stiff shoulder because of an inflammatory arthritis and the rotator cuff is good, young patient, it would be a total shoulder. And it's interesting that we're talking about this. Just last week, we did a total shoulder for a patient with a monoarticular rheumatoid shoulder. Patient's age was barely 38. Now, the same thing, if the patient is presenting with a rotator cuff tear with arthritis and a stiff shoulder because of an inflammatory condition, then probably a reverse shoulder would be the answer. But by and large, to avoid any confusion, let me put this in print that for an idiopathic primary frozen shoulder, arthroplasty is not a treatment option.
Yes, Dr. Kamath, again, very rarely done. And even if it is, then we would want to restore the patient's activity. So again, we would consider if the patient is quite young or would want to do some particular activity with their shoulder, which is really they are dependent on. Okay, the next question to Dr. Sania. So, do you have a particular exercise protocol you want to follow for any frozen shoulder? Again, it is going to be quite tailor-made given the comorbidities of the patient, their occupation, the activities they do in all of their the whole of the day. So, do you still follow a particular protocol that you want to go ahead with?
I don't follow a particular protocol per se, but if I want to jot down the points, so as the condition is the restriction of movement, so first I would want to regain the movement and then work on the strengthening part. Now we see many patients coming from say outside of Pune or from some other clinics. Physios telling them that no, you don't have enough strength. You have to start working on your strengthening part. That is again not right according to me, because first, if you do not have the movement only, you do not have the proper biomechanics for the muscle to act. So first, you should get in the movement. Now, depending on the cause of the restrictions. So suppose one patient, consider one patient who is in a lot of guarding. That patient really doesn't require any joint mobilizations per se. Just instead of telling the patient to relax and just assistance to the movements without giving any mobilizations, you can achieve ranges. But in a long standing case, if the patient is presented to you with a lot of stiffness, all the muscles are tight around the joint, in that case you should go with the joint mobilization along with active assisted movements and strengthening in the end part.
Yes, that is much more required here. We want to get the movement first, start focusing on the biomechanical advantaged movement here, and then start correcting whatever trick movements they tend to do or whatever dyskinesia the patients come with. So, Dr. Kamath, we have one question from the chat. So, there's a question saying that they want to know your opinion on steroid injections in conjunction with therapy for frozen shoulder, and if it is really effective in all stages of the frozen shoulder.
Right. So, I mean, uh, indication for frozen for a steroid injection is when patient is not responding to conservative treatment. When I say conservative treatment, it means rest, it means SOS, NSAIDs, it means modality. If in spite of all of that, if patients are talking about significant night pain, and I know that the sugars are well controlled, that is when I would offer them a steroid injection. Whether to top up a steroid injection immediately with physical therapy, again the same rationale, till the night pain does not go down, still is not going to see the physio for exercising, right, to gain mobilization. I would wait till I actually get the patient to be reasonably pain free, and that is when he is going to start off with exercises. The idea of steroid is as a part of pain management. It's not. It's to accelerate the to push him from the inflammatory phase into the frozen phase. That is what the rationale is, right? So that's what I would consider.
So, considering the same steroid injections here, so again, you wouldn't want to do it with each and every patient. But again, if you have to give a comparison with oral medications or the steroid injections, which one do you think is better?
So we have a varied thought process here. So if you look at someone by the name Professor Young Girl Ree from Korea, right? He believes that patients should get both oral steroids as well as an injection at the same time. And if a patient is diabetic, and this is something he said on stage in a public forum, that if patient is diabetic, it's not my headache, it's the headache of the physician. But he believes that steroids are something which are really, really effective in controlling the inflammatory condition and to push forward into the next phase. So if I were to kind of summarize what the thought process is, the thought process is simple. As shoulder surgeons and as shoulder physios, you're not going to alter the natural history, but you will try to accelerate the phases so that patient from one phase goes into the next phase faster and that finishes all those three phases faster. Very rarely will you see someone who will skip a phase completely and from first phase become directly normal. Very rarely. You do see that very occasionally, but then probably then the diagnosis itself is suspect. But by and large, our job is to shorten the phases rather than trying to cure the phases.
Yes, sir. Because again, for frozen shoulder, the most basic management we do is going to be the treatment of the symptoms itself, and not exactly curing the condition. So the next question is going to be for Dr. Sania. So, do you want the patient to go through or push through the painful shoulder or the painful phase and then achieve the actual exercise you want or the actual range of motion you want? Uh, do you consider that it is going to be helpful or it is going to go the either way and it is going to worsen the?
No, I guess by now everybody knows my answer because I have stressed it a lot of times. No, you do not get results if you push it a lot. There comes the clinical judgment. You have to feel for the end feel, and you really have to judge how much pain and what pain. Good pain and bad pain, you have to identify that, and good pain you have to give to the patient. no pain, no gain theory doesn't work always. So I don't think.
Some pain would be expected, right? But it's a very fine balance.
Yeah.
Very fine balance.
And that definitely, even I don't know much, but that comes with experience. You see more and more shoulders, you will come to know. It's like that.
One thing which I also try to ask the patient is, has the pain increased? See, the pain can remain more or less same, or it should be on the decline. But if the patient says that post physical therapy my pain is increasing, that means we are not doing something right, right? So that's for sure.
Yes, sir, that is true. So, again, we have seen that the etiology or the stats say that there is a possibility for a patient to get the frozen shoulder twice, but very seldom it is going to be on the same shoulder. So, there is a possibility that a patient comes to you with a right frozen shoulder and maybe comes to you after 2 or 3 years saying that he's having the same symptoms on his left hand also. So, you want to comment anything on that, Dr. Kamal?
So in medicine, it is never say never, right? I mean, it may happen, but it is rare. There's nearly a 30 to 35% chance that you have bilateral frozen shoulder at different point of time in your entire lifespan, but the same shoulder getting affected, it's a rare possibility. But having said that, I wouldn't say it'll never happen, because the second time it could also be an acquired shoulder. But yes, never say never. I think one more question which was missed is that someone had asked that night pain is a big problem and patients are not able to sleep. So they wanted to know if there is any particular posture which will allow the patient to sleep, or any particular medication that would allow the patients to sleep. So one thing's for sure, that NSAIDs by itself do not allow them to sleep well, because the pain does not decline or the pain does not go away completely. In that setting, what I have started using in my patients is pregabalin, and pregabalin has started showing brilliant results. Right? Yes, patients do feel drowsy for some time. I don't deny that, but it's typically an adaptive medicine. You can even start with half a tablet of pregabalin, 75 milligram, in a sustained release preparation. Get them to adapt to it. The advantage is, because this is a neurotropic drug, you can give it for a longer period, right? You're not going to have nephrotoxic effects. But we know that if the patient sleeps better, he's more amenable and more compliant to physio the next day, rather than wanting to do physio being in pain and not sleeping. So that's something which I have started in practice, that we have been routinely using pregabalin now for probably over a couple of years now, and I think we are very happy with the way things are shaping up.
Yes, sir. To add more on that, as a physiotherapist, I would want to also counsel them or give them some sleep ergonomic advices. Again, I somewhat feel this is missed quite a lot of times, especially when it is a shoulder condition, that when the patient says he's comfortable sleeping on the affected side down or the affected side up, then I would want to make sure that the joint is quite supported. So if the patient is going into sideline, being the affected side on the top, so I would want to tell them to use a few more pillows in front of them, so that even if they are taking their shoulder into flexion, they have quite support from the pillows itself. And even when they are going to sleep in supine, which most of us do. So, sleeping in supine, I would also want them to use a small towel roll, which is, I know it is going to be quite cumbersome for the patients to manage, but a small towel roll behind the shoulder itself. So, again, there is a possibility that the patient can go into so much of guarding, and it is a possibility that the shoulders may not even touch while they were touch the mattress or the bed whenever they are sleeping supine. So, again, using whatever we have around us, maybe more pillows for support, maybe using a few more towel rolls or maybe some blankets to give the support to the shoulder itself, is going to also help reduce their night pain. I still feel that. And again, after some point of time, the patients are so vulnerable to or even apprehensive to the pain that they tend to sleep or sleep quite stiff in one position and not move around the whole night. So again, coming back to the physiotherapist point of view, if the patient is going to do something like that, Sanya, do you advise these sleeping positions to your patients?
Yes. Uh, there comes the the part of patient education, because that is the reason you have to be empathetic towards your patient. You have to gain the trust, and you have to make sure that you have to tell them that, okay, these sleeping positions or these postures will not give you pain, and these activities or these postures might give you pain. So you have to develop the confidence. Basically, you can mimic the same in your clinic or in your OPD basis, and you can make them do, okay, go and try in this position and see whether it is giving you pain or no. So it is really going to be trial and error, because one position or one posture does not work for everybody. So some patients might be comfortable lying down in supine position, some are not. So it is going to be trial and error, but the patient ultimately will be finding his comfortable sleeping position.
So if I may add here, just one
Yes, sir,
thing that I
please.
ask you to do is have a hot water shower if possible before sleeping.
Yes.
Because somehow that kind of makes them feel a little more comfortable.
Yes, sir.
And the interesting, and this is something I learned from my patients with a rotator cuff tear, is that, or rather rotator cuff surgery, is that I ask them to take a bolster in front of them. So if it's the right side, you're going to get into the left lateral position, right side
Hugging
being up, keep a bolster in front of you and hug the bolster
Hugging
and
position.
sleep.
Yes, sir. Yes.
That really helps,
That
I
really
think,
helps.
because this is a patient feedback saying that yes, we were able to sleep a little better.
Yeah.
No one ever says that they were able to sleep completely in a sound deep sleep,
but at least for some hours.
That's what we need to do. Baby steps is all that we need to do here.
Yes, sir. And some patients actually also tell us that lying on the same side relieves the pain. So that pressure actually, has that pain relieving effect. So that's why I said.
I think there are a few more questions lined up here. One is exact time or stage to consult a shoulder specialist. If you have a good shoulder physio, you don't need a shoulder specialist, because anyways, this is going to resolve. It's okay. So it's only for pain management perspective, or if you feel that things are not progressing as well and you want to be sure that nothing else is being missed, that is when a shoulder specialist comes into picture. Otherwise, as we have discussed over and over again, that this is a condition which will run through its natural course, and physiotherapist colleagues are in a better position to treat this than the shoulder surgeon himself, because all patients will require physio. Less than 1% patients will require shoulder surgery. So that's the equation, and that will answer your question. That really is a specialist opinion required. Answer is only to rule out other conditions, right? So that is something which is important. Is heat or ice better for frozen shoulder? Can't really predict, because some patients, as Sania mentioned, when they're in that acutely painful stage where it's excessive pain, right, in the inflammatory flare up, those patients tolerate pain a little better, as opposed to those who are in between that inflammatory and frozen phase where they're getting tight on themselves and they're painful. They like heat. So I clearly ask the patients, what is it that makes you feel better? And if they say that, yes, it's heat, I allow them to do heat. If they say it's ice, then I allow them to do ice. By and large, patient dictates this rather than me dictating this, right? I think there's a question for Sania. Is acupuncture better? Okay, one more question. Is there dietary restriction? No, I don't put them on any dietary restriction for frozen shoulder, right? And for Sania and for Nikita, there's a question that, is acupuncture good for frozen shoulder?
Right now, I don't have any supportive articles whether acupuncture is better or not. So if I will just pass on this question to Dr. Nikita if she has anything to talk on this.
Yes. So again, acupuncture as such, again, the whole principles behind using acupuncture in pain relief is going to be quite different. Though we don't, I mean, as physios, we very rarely use acupuncture for treatment for our patients. But again, we do have some, what do you say, a parallel technique or a relatively similar technique called a dry needling. So again, here I wouldn't directly go dive into choosing dry needling as one of the main treatment modality for a frozen shoulder. But again, if I still feel that there are quite an amount of trigger points or quite an amount of what you say triggers along the trapezius or along the pectorals or along the rhomboids or even the deltoid for that matter. So if I want to treat those triggers so that the patient is able to do the activity or do the exercise better, then I wouldn't mind using the dry needling. But as such, for acupuncture, yes, we do have quite some amount of studies that were done, but again, very rarely they are done by physios, so I wouldn't comment on it.
I would like to add, again, dry needling, it is known to cause some soreness. So when you are giving dry needling, the phase is very important, because again, you don't want to increase the soreness, thereby increasing the pain. So dry needling, definitely it works. It gives relief to the patient, but when you are going to do it and where you are going to do it, whether you are going to go very deep in the, like, you want to reach the capsule, or you want to do it only for the superficial muscles. So that also, I guess, is important.
Yes, Dr. Sanya. So considering as a personal experience, I wouldn't want to give it in the capsule itself. So even if I want to, again, coming back to the same thing, I want the patient to get back to their activity as better as possible than as soon as possible. So I would want them to do their activities in a proper biomechanical chain, but again, that is going to be quite different for each and every one of them. But I would want them to do these activities with very less energy cost here. So for that, I would want most of their muscles to be pliable enough, most of their muscles to be contracting in a better way. So again, as you told, considering the stage of the frozen shoulder, it is very important that we know when to give it. Again, I would want to give it in the thawing phase when I know they are getting back to their activity, and I would want to improve on their activity, again, the quality of activity as I'm talking about. So again, in that stage, I would want to use it. Dr. Kamath, there's a question for you. Is
Yes.
there any age factor for a frozen shoulder?
I think shoulder itself is peculiar to the fact that most of the conditions are age related. Right? No other joint has so age specific conditions, right? So if you, and again, never say never. It can affect any age group, but by and large, if you were to look at frozen shoulder, you're looking at that 30 to 55 age group where they would land up with a frozen shoulder. Above 55, it's less likely, but many times you need to rule out a rotator cuff tear. Prior to your 30s, in a younger patient, many times they have a posterior superior labral tear or a slap tear, or itself they have a GERD kind of picture where they have a glenohumeral internal rotation deficit, and that by itself can be causing symptoms. But 30 to 55 is the age group that we are looking at.
Again, I think there's one last question. I really want to address it, but I request Sanya to take the question first. Can we do massage in frozen shoulder?
Yeah, commonly asked question. So massage has to be scientific. What patients expect or what patients know is just some hand movements, which is or the some manipulations or some techniques which are basically soothing or relieving. So that massage is okay, or I would say, if it is just relieving pain, that is fine. But if you are going to a masseuse and masseuse is going to perform some dynamic movements, or if he is going to do something which will cause more pain, or which is not scientific, or which is not the functional or anatomical movement, I don't think patients should go for it. What do you think? Do you want to add anything?
Yeah, here I want to add. See, as Indians, we always have that कि barber shop में जाएंगे, वो कुछ टक टक आवाज कर देंगे, then the cracks are going to relieve my pain because there is something stuck in my joint that has to be relieved. Again, here we have to understand that getting that noise is not necessary, or for that matter, the massage itself. Why do you want to do it? We have to know that when we have to do the massage. So as Dr. Sania said, it has to be scientific. So if I have a muscle spasm, then I would want to go ahead with the massage. If I have a trigger point, then I want to go ahead with the massage. If there is a small or if there is sudden bout of inflammation, then I would stick with a simple stretching. For example, just the capsular stretching for that matter. And again, I would refrain from advising the patients to go ahead with a massage, or you're just going to increase the inflammation at the end of the day, even if you're getting one. Again, if the person doesn't know how the joint is anatomically placed, just moving the joint with rigorous movements, or um, just giving them some clicks and sending them back is not going to help. And in fact, it is again coming back to the same. It is going to inflame your joint much more, and it is going to be back to square one. And you start with the same pain relieving modalities, you start with the same ROM exercises, and so forth. Dr. Kamath, you want to add something on that? Have you ever encountered a patient coming to you after taking a massage?
So we've seen patients who have been to bone setters and land up with issues and land up with fractures because of a so-called massage or a manipulation or whatever it is, right? I'm very worried about it. I don't really ask them to do any massage. If at all anything, I do ask them to do a gentle oil massage, but by themselves. Because you really can't cause pain to yourself, right? But what that would do is that would enhance the blood circulation. And yes, if there is spasm, if there are myofascial triggers, that's going to ease that down. Many times patients are very concerned about the deltoid spasm, right? They will land up and say that देखो यहाँ swelling आ गया है, ये कड़क हो गया है, right? They would always, practically all of them would say that. You ask them to do a gentle massage out there that acts both as placebo, that acts in reducing that spasm, that makes them feel that you have addressed their complaint. So all in all, that works better. But the trick is that they will do it themselves rather than someone else doing it for them.
Yes, Dr. Kamath. Again, giving them controls of doing the massage for themselves and then relieving their own pain would be a better option again than going to some quack and getting it done for them. Okay, so I guess we have answered almost all the questions that we have. So I guess we can sign off for today. Thank you, Dr. Nilesh Kamath. Thank you for your enlightening session that we got to know what exactly a surgeon thinks of when they are referring or when they encounter the frozen shoulder patients themselves. And thank you, Dr. Sania, for giving us inputs on what, as a physiotherapist, I have to keep a watch for the patient, especially for the pain, for their posture, for the exercises itself. Again, we just prescribe the exercises and forget that the patient can do the trick movements. So telling them to do it in a right way is also as equally important. Thank you, Dr. Nilesh Kamath. Thank you, Dr. Sania. Thank you, Physio TV, for organizing this session. Thank you, Sancheti Institute, for giving us this platform to increase the knowledge across the globe, I hope, across the globe, and for the surgeons, for the physios, for the physiotherapists. And thank you, one and all. Thank you for the technical team for organizing everything. Thank you so much.
Thank you, Dr. Nikita, and it's really been an honor. It's a pleasure to be a part of this academic forum, and let's hope that we get to meet each other on many more such academic forums and try to learn from each other. Thank you so much.
Thank you, sir. Thank you.